Can a text messaging service improve outcomes for patients with tuberculosis who want to quit smoking? What's the best strategy for RSV prevention in infants? What is the efficacy of spinal manipulation therapy in patients with low back pain? This and much more on today's JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Happy New Year! Today is Friday, January 2nd, 2026. I'm Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today, I'm excited to be joined by JAMA Deputy Editor, Dr. Preeti Malani. Hello, Preeti. Let's get started.
Hi, Kirsten. We have some great content to start the new year. Dr. Zahid and colleagues report findings from a multi-center cluster randomized clinical trial about a smoking cessation intervention for individuals with tuberculosis, or TB. The investigators included 1,080 people aged 15 or older who had recently been diagnosed with drug-sensitive TB, smoked daily, wanted to quit, and had mobile phone access. Participants in 27 TB clinics in Bangladesh and Pakistan were randomly assigned to either a mobile health intervention called mHealth or a usual care group. The mHealth intervention consisted of text messages sent throughout TB treatment, daily for 2 months, then monthly for 4 months, encouraging tobacco cessation. The usual care group received written information on tobacco cessation. The primary outcome, continuous tobacco abstinence for 6 months, was confirmed using a breath test. Secondary outcomes included self-reported quitting rates at 9 weeks and 6 months, along with a number of TB-related outcomes, including medication adherence, treatment success, and death. The investigators reported that 41.7% of those in the mHealth group who received regular text messages encouraging quitting had quit smoking at 6 months, compared with just 15.3% in the usual care group. TB treatment success was slightly higher in the mHealth group, and fewer people died in this group. These findings suggest that using regular, supportive text messages may be a practical and effective way to help people with TB quit smoking.
An accompanying editorial by Dr. Shooter and colleagues really underscores the importance of this problem. It turns out about 17.6% of tuberculosis cases and 15.2% of tuberculosis deaths in countries with high TB burden are attributable to tobacco smoking. And so these authors reiterate the trial findings. A simple text message program helped people with TB quit smoking at much higher rates than usual care and reduced death rates, which was a secondary outcome. The authors note that the program is low cost, potentially easy to deliver, and could save many lives if implemented widely, especially in countries where resources and access to face-to-face support are limited.
It's a great study and important information. Next up is another clinically important prevention study. Respiratory syncytial virus, or RSV, is a leading cause of serious infections in infants, and both the long-acting antibody Nirsevimab and the maternal RSVpreF vaccine have been shown to be effective in reducing RSV hospitalizations in infants. This population-based cohort study by Dr. Jabaji and colleagues used French national health data to compare 2 RSV prevention strategies in newborns. The investigators included more than 42,000 infants born in France between September and December 2024, evenly split between those whose mothers received the RSVpreF vaccine during pregnancy and those who received Nirsevimab as infants. The primary outcome in the study was hospitalization for RSV-related lower respiratory tract infection. Secondary outcomes included admission to intensive care, need for ventilator support, and oxygen therapy. The authors report that infants given Nirsevimab had lower rates of RSV-related hospitalization, intensive care admission, and need for respiratory support than those whose mothers received the RSVpreF vaccine. The Nirsevimab group had fewer RSV-related hospitalizations, 212, compared with 269. They also had lower risks of severe outcomes, including admission to the ICU, need for ventilator support, and oxygen therapy, compared with the RSVpreF vaccine group. These differences were consistent across several subgroups. The study suggests that direct immunization of infants with Nirsevimab may be more effective than maternal RSVpreF vaccination in protecting newborns from RSV hospitalization and severe illness during their first RSV season.
Next, JAMA published the PACBAC randomized clinical trial, which addresses a very common clinical concern, lower back pain, a leading cause of disability around the world. Current evidence supports remaining active using non-pharmacological treatments and clinician-supported self-management for acute cases. This trial tested whether spinal manipulation, clinician-supported self-management, or both are more effective than standard guideline-based medical care in reducing pain and disability for patients at higher risk of developing chronic back pain. Dr. Braunfort and colleagues conducted a 2x2 factorial RCT at 3 research clinics from 2018 to 2024. They included 1,000 adults with acute or subacute low back pain at moderate or high risk of developing chronic pain. The 2 primary outcomes were low back disability, measured monthly using a validated questionnaire, and pain intensity, measured weekly, averaged over 1 year. The researchers report that clinician-supported biopsychosocial self-management led to statistically significant, though small, improvements in disability compared with guideline-based medical care, although there was no difference in pain. Spinal manipulation alone did not differ from medical care in either disability or pain. The authors conclude that supporting patients in managing their physical and psychosocial needs can somewhat reduce disability with back pain, and that spinal manipulations alone are no more effective than standard medical care for this purpose.
Switching topics, let's talk about older adults with cancer, who often have untreated symptoms. Dr. Patel and colleagues evaluated whether monthly symptom check-ins by lay health workers could reduce emergency department visits and hospitalizations. The investigators conducted a multi-site randomized clinical trial across 43 oncology clinics in California and Arizona from November 2020 through October 2023 and included 12 months of follow-up. The 416 participants were Medicare Advantage beneficiaries aged 75 and older with newly diagnosed, recurrent, or progressive cancer. 41% had stage 4 disease, and 6% had recurrent cancer. Their median age was 82 years, and nearly half were Hispanic. The primary outcomes were emergency department visits and hospitalizations. The authors found that participants who received monthly symptom check-ins by lay health workers using phone calls and a standardized symptom scale had 53% lower odds of visiting the emergency department and 68% lower odds of hospitalization over 12 months compared with usual care. They also averaged $12,000 less in healthcare costs per person.
In the accompanying editorial, Drs. Wright and Enzinger highlight that this is a trial of a low-tech cancer care model for older adults, using lay health workers to check in with patients by phone and report symptoms to specialized clinicians. They emphasize that the results suggest how simple person-to-person interventions may greatly benefit older patients with cancer, especially those who are less comfortable with digital systems.
Kirsten, let's talk about some JAMA research letters. Medicare beneficiaries with cancer often face high out-of-pocket costs for specialty oral anti-cancer medications, which can prevent them from filling their prescriptions. In 2024, the Inflation Reduction Act capped these costs for Medicare Part D beneficiaries without low-income subsidies, aiming to make cancer drugs more affordable. In their research letter, Dr. Doshi and colleagues used a national insurance claims database to analyze prescription fill rates for new insurer-approved specialty oral anti-cancer medications among patients with solid tumors during 2023 and 2024. So this was the index prescription. They compared patients who got cost relief from the Inflation Reduction Act, non-low-income subsidy group, with those who continued to receive full subsidies, the low-income subsidy group, looking at average costs and how often patients picked up their medication within 60 days. After the new policy, out-of-pocket costs dropped by more than $500 for non-subsidized patients, and their prescription fill rates increased by nearly 14 percentage points, with more patients picking up drugs within 60 days. However, despite this policy, less than half of non-subsidized beneficiaries filled their prescriptions, suggesting that capped costs were still too high for many older adults. This study highlights that while cost caps help, some patients may still struggle to afford vital cancer medications.
Dr. Dupree and colleagues have a research letter on fertility clinics. Infertility affects about 1 in 8 reproductive age women in the U.S., with in vitro fertilization, or IVF, as a key treatment. In recent years, private equity firms have become major financial partners with fertility clinics, which may impact cost, quality, and access to care. This study analyzed U.S. fertility clinics listed in the U.S. Centers for Disease Control and Prevention annual reports from 2013 to 2022, identifying private equity affiliations using merger and acquisition databases and public reports. The researchers calculated the number and percentage of IVF cycles performed at private equity-affiliated clinics, estimating 2023 volumes. The percentage of fertility clinics with private equity affiliations rose from 3.7% in 2013 to 32.1% in 2023. These affiliated clinics are estimated to have performed 54% of all U.S. IVF cycles in 2023, with some U.S. states seeing up to 100% of IVF cycles at private equity-affiliated clinics. The rapid growth of private equity in infertility care suggests important shifts in how and where Americans receive reproductive treatment, raising questions about future effects on cost, quality, and accessibility.
JAMA published some interesting viewpoints the past 2 weeks. California's new law, Senate Bill 243, requires AI companion chatbots to disclose they're not human and offer support if users discuss suicide or self-harm, especially for minors. While this sets a national standard for safety, authors Professor Cohen and Dr. De Freitas argue that stronger measures are needed to truly protect young users. And Dr. Aaron and colleagues discussed the FDA's plan to approve Leucovorin as a treatment for some patients with autism or autistic features. They advocate that this approval risks lowering long-standing evidentiary standards for drug approvals and may undermine public trust in FDA decisions.
With some more viewpoints, Dr. Xu and colleagues explain how designating opioid overdose as an ambulatory care-sensitive condition would encourage U.S. health systems to prioritize outpatient prevention and evidence-based treatments, which could prevent hospitalizations and deaths. According to the authors, this shift could help address gaps in care, making overdose prevention part of routine quality measurement and expanding access to life-saving services for those at risk. And in another viewpoint, Dr. Sontag and Levinson note that medical educators are under political pressure to avoid teaching about topics like racism and health equity, threatening the integrity of medical education. The authors urge institutions to stand up for evidence-based teaching on all factors affecting patient care.
The latest patient page is on superficial vein thrombosis. It's a great resource for patients to learn about risk factors, symptoms, and the management of superficial vein thrombosis. Test your diagnostic skills with a clinical challenge from Drs. Yan and Margaretin. What would you do next for a patient with rheumatoid arthritis and a vesicular rash? Don't forget to tune in to the final JAMA Clinical Reviews podcast for 2025. JAMA Deputy Editors Dr. Mary McDermott and Dr. Kirsten Walter discuss some of the most downloaded JAMA Clinical Reviews podcasts of 2025.
Doctors Chen and Go sit down with JAMA and JAMA Plus AI Associate Editor Dr. Yulin Xuen to have a follow-up conversation about the latest generation of AI models and AI chatbots in the JAMA Plus AI Conversations podcast. Let's listen to a clip of their conversation.
Why do we trust AI so much?
I think there are two parts to it. One, we need to remember that these things are trained to be super engaging because the metrics from these companies are like, great, if people are using our product more, that helps our business, right? So that's the first part. Second part, I think it was a broader commentary. If things are generally correct, right? Like you go to a doctor, you expect his expert is always saying correct sounding things. And who else would you have to turn to, bearing in mind that most people don't have a doctor or someone in the family? So in that instance, ChatGPT might sound like it's giving to them the best advice. And when things are 95, 97, 99% correct, are they going to miss like the 1% of things that are wrong, right? So I feel it's a lot of that, but that's my take. I don't know if Jonathan has a added take to that as well.
I would say the specific word is automation bias, right? When something is right 90+% of the time, it's a supervision fallacy. We're here to double check the AI's work, right? When it's right that often, you eventually just will stop paying attention. It doesn't pay off to double check that often when it's right so often. And this isn't AI specific. This is all sorts of processing technology. That is a real issue. You follow the same guideline protocol. I'll give a concrete anecdote. In our children's hospital, right, we take care of a lot of babies are born, our OB-GYN residents are taking good care of them. And then one day, like Epic went down, right? And people had to go back to like pen and paper to get in orders. And the new baby was born, yay. So go take care of the new baby orders. And the resident like, wait, what are new baby orders? I think there's some vaccines. I think it's like a vitamin K shot. Like they don't remember anymore because the computer always just took care of it. And that is like a sensible thing to do. But you can see what happens when we become dependent on technology for something. It enables us to do a lot, but technology availability can also cause issues when we're so used to trusting it.
There's also been a lot of rapidly developing medical news. Our outstanding JAMA medical news team stays on top of it all and gets you the latest articles in clinical medicine, biomedical research, public health, and health policy. Find it all at jamamedicalnews.com or click on the link in the episode's show notes.
Thanks, Preeti. And thank you for tuning in to hear what's new at JAMA. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.